So tonight he will guide us through the evolving world of add-ons, optional treatments used in IVF protocols, and will help us to clarify which may offer potential benefits and which remain uncertain, and how to make those choices that are right for you. And throughout the session, we invite you to submit all the questions through the chat feature in the Q&A box, and we will address as many questions as possible. So thank you once again for joining us this evening. We are absolutely honored to support you in the fertility journey, and hope tonight's conversation will bring greater clarity and confidence in your decision-making process. And Dr. Reshef, the floor is yours. We must have some difficulties. Allow us one moment.
Webinar. Okay. Can you still hear me?
Dr. Reshef?
Okay.
Wonderful.
Oh, all right.
Can you see my slides right now?
Hold on.
I apologize for all the technical difficulties. Sometimes it's happened and the system is not cooperating with us. And we hope to sort everything out momentarily.
Well, I promise you, everybody, if you can hear me, that I'll make it up for you to you. But right now
I can hear you.
Yeah, but I cannot see the slides. Okay. You already joined, join here.
Can I ask the audience if you see the slides that displayed? If you can please answer the question in the chat, if you see the slides.
Can you hear me, Irina?
Yes, I can hear.
Are we on?
Okay, and you can see the slides as well?
I can see the slides.
Okay, wonderful. I appreciate it. Thank you. We can take away.
Well, everybody, I apologize for the technical difficulties. It's modern technology. I'm Eli Resheff, and I assume you already introduced me, but I couldn't hear you, Irina. So I will start with a little statement about what I'm going to be talking about, because this is a controversial topic. And uh, first of all, some of the add-ons that I'll be discussing are not available in every one of our Inception Prelude clinics. And number two is that this is my opinion based on obviously medical evidence and otherwise, but does not reflect the opinion of Inception or any other physicians. The beauty of being even part of a network is everybody is free to practice their way. So you are hearing one opinion, one physician, and today we're talking about add-ons, trick or treatment. Next slide. Back. So we're talking about good practice recommendations on add-ons in reproductive medicine, and this is primarily taken from a very, very good research that was done in the journal Human Reproduction in November. It was published in November of 2023 by the European Society of Human Reproduction and Embryology, a very, very respected body. And they had a working group. Next slide. So this is not just one study. This is basically a very thorough analysis of many, many studies rather than just going to look at one supportive or non-supportive study. And I'm going to start with what I consider interesting statement by a senator from Missouri that said, I come from a state that raises corn and cotton and cockleburs. If any of you know what cockleburs are, and Democrats and frothy eloquence neither convinces me or nor satisfies me. I'm from Missouri, show me. And that's why the motto of the Missouri state is show me. The reason I mention that is because some of us physicians would not allow any modifications to their practice unless research has shown that they work. And so we'll talk about how we relate to that particular statement of show me. Remember that, and let's move on to the next slide. So evidence-based medicine is something we all aspire to practice. And evidence-based medicine essentially is the integration of clinical experience, physicians' experience, other healthcare workers' experience, patient values, and best scientific evidence. And you can see the definition there, the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Sounds good, sounds complicated, but remember that medicine has been practiced for thousands of years, and you cannot say for thousands of years we've practiced it wrong because we didn't have evidence. So in the hierarchy of evidence, EBM, evidence-based medicine, if we have systematic studies, especially those with randomized controlled studies, that's the top of the evidence. Obviously, expert opinion and case reports are at the bottom of that. Next slide. However, evidence-based medicine utilizes all of them. Let's go on to the next slide. There we go. So let's talk about add-ons. And basically, add-ons are the optional additional treatments used in addition to the standard IVF protocols in an attempt to improve success rates. Of course, it's an honest attempt to get better and better and give patients a better chance of a live birth. Remember that in vitro fertilization has been around since 1978, so that's 47 years. And we've gotten better over the years. Success rates have evened out most recently in the last 10, 15 years because we started moving to single embryo transfers to reduce multiples. And multiple births, as you well know, and we're not going to talk very long about it, involve prematurity, and prematurity may create compromise, health compromise, or even life and death compromise to babies that are born, especially those with extreme prematurity. So the idea is not just to get a positive pregnancy test. The idea is to get healthy child or healthy children. So I'm going to go over them very quickly. Screening hysteroscopy is what some of you, your physicians, may offer you before you do embryo transfer, just to make sure you don't have polyps, scar tissue, uh, birth defects in the uterus, fibroids that interfere with implantation. Human growth hormone, also known as omnitrope, obviously it's on the agenda all the time. Many patients ask about it and request it. Steroids, uh, dexamethasone, prednisone during either the retrieval or the stimulation or during transfer, oftentimes are a popular topic. Lovenox, a blood thinner, a relative of heparin, baby aspirin, metformin, which is a medication for diabetes, but also helps polycystic ovarian syndrome. Priming the cycle to get better stimulation, maybe more eggs or more mature eggs, by either estrogen, testosterone, or combination thereof. ERA, endometrial receptivity assay, which is now falling out of favor, involving a biopsy of the lining to look at receptivity. EMA is essentially a complicated name for checking the bacteria in the uterus to see if they may interfere with implantation. Receptiva is a commercial name, looking primarily at the protein called BCL6, that may be associated with endometriosis and may reduce your chance of implantation. Immune testing and therapy. The endometrial scratch, meaning doing a biopsy just for the fact of irritating a lining, so implantation will be more likely. Viagra to improve blood supply to the lining of the uterus. And of course, some of what we call part of the autoimmune or immune protocol, which is Pepsid and et cetera. Let's move to the next slide. Those are clinical add-ons. Those are add-ons that your physician may discuss with you. Some of your physicians may not believe in them. Some of them may, but clearly it's worth discussing with your healthcare provider. Lab add-ons. So remember that ICSI, intracytoplasmic sperm injection, is an add-on. It was only created in 1992. I know many of you have not been born then, but clearly it's not that old, and it was not part of the original IVF. Freezing all embryos as opposed to doing fresh transfer. Embryo glue to improve implantation or the embryo sticking. The additional hyaluronic acid to the culture. Calcium ionophore to improve fertilization and egg and embryo or formation to embryos or egg maturity. Assisted hatching, which is essentially making a little breach in the hard covering of the embryo to improve implantation. Sperm DNA damage tests. They're all add-ons. Microfluidics, which is essentially actually sorting out the sperm. This is a lab add-on. Some people call it Zymot. That's the commercial product. I'm not going to talk about MC because has fallen out of favor, but also time-lapse imaging, in which the lab has on the incubator cameras that continuously monitor the growth of the embryo without having to open and close the doors, which might have an advantage in terms of survival of embryos. Next. So back to the study, and this was serious stuff. I mean, they reviewed the literature, they used randomized control studies, they even used patient representatives and lay people, and basically used the guidelines based on the best available evidence. And prior to publication of that, just to tell you how rigorous the study was, they were reviewed by 46 independent international reviewers. So one cannot accuse that article in November 2023 in Human Reproduction as biased. Next slide. So they created categories for recommendations. It's like a green light, orange light or yellow light, and red light. A recommend, that's in green, can be considered CBC or currently not recommended for routine clinical use. That's the yellow light, and then not recommended in red. So next slide, and what you see, unfortunately, is that most of those add-ons do not have green lights. So let's go over that. Screening hysteroscopy. not recommended for routine use, can be considered for recurrent implantation failure. Endometrial receptivity tests, not recommended anymore. That's including the ERA. Reproductive immunology tests and treatments, such as testing for natural killer cells or using intravenous immunoglobulins and intralipids, those are not recommended. And that's the next point, but that's also infusion of other substances, either into the uterus or intravenously. They do not have any merit. So you see a lot of red here. PRP, which is platelet-rich plasma, has been on in the media now and very popular, but PRP has not been shown to be universally helpful at this point. There are ongoing studies. Duostim, I'm sure you heard about the back-to-back stimulation, starting stimulation right after your retrieval took place, and that's not recommended for routine use. Other things, baby aspirin, human growth hormone, testosterone, DHEA, Viagra are not recommended. And I realize that by talking to you as either patients or a relative of patients or even healthcare providers, I may disappoint some of you, but I can assure you that this is a very thoughtful analysis, not a fly-by-night guidelines. Steroids are not recommended. Antioxidants therapy, and you've heard about CoQ10 and vitamin E and vitamin C, they're not recommended. They do not have any merit. Now, complementary and alternative medicine, that's controversial because that includes acupuncture and yoga and Pilates and all that. They're not recommended, but, and you'll see later on that I do recommend them because they reduce stress. Now, does acupuncture or does yoga or Pilates, are they associated with improved pregnancy rates? No. But they reduce the stress associated with a very difficult journey. Next slide. So, with regards to laboratory add-ons, and I will, artificial oocyte activation by calcium ionophore, I know I'm using a lot of jargon, not routinely recommended unless you have complete fertilization failure in the lab. In vitro maturation, not recommended for routine use. DNA testing of the sperm, not recommended for routine use. Microfluidics, so Zymot can be considered. So in a way, it's orange, but it has a tint of green. ICSI, interestingly, we use a lot of ICSI, injecting the eggs with sperm, not recommended for routine use. It's primarily for male factor, but universally, it's not recommended. Yet we use it quite often, especially when we do pre-implantation genetic testing. Growth factor supplementation, not recommended. Assisted hatching, not recommended. PGT, which many of you either are considering or have gone through, not recommended for routine use. That's hard to hear. Now, look at the green. The one only green that you'll see in this entire tray is embryo glue in order to improve implantation or the embryo sticking to the lining. It's green. And elective freeze-all is not recommended for routine use. Next slide. So here's a question. Should we only offer scientifically proven add-ons? In other words, should we use the Missouri approach of show me? If it's not proven, let's not use it. Some of us physicians believe that. I do not. And here's my opinion. No, because much of medical practice involves therapies that are either unproven, poorly studied, or unapproved. And remember that 50% of the medications you use are not approved by the FDA. Okay, surprise, surprise. Most of these are not harmful, motivated by caretakers' desire, like me, to better the health of patients or improve your outcome when it comes to pregnancy rate. Next slide. So here's what I strongly believe in. There are certain principles of medical ethics that we should stick to as healthcare providers. Autonomy. You have the right as a patient to be autonomous as long as you're empowered to participate in the decisions, as long as you're well informed about the pros and cons. So you need to be assertive. Non-maleficence simply means we should do no harm. That's the hallowed principle of medicine. We need to keep that in mind. Beneficence is the other side of it. Let's make sure that something works or benefits you. And of course, informed consent. Next slide. And here's a statement that providing IVF add-ons might be morally acceptable in several specific circumstances. If true, informed consent can be given, there's a potential of cost-effective physiological or psychological benefit, and the risk of harm is minimal, particularly with regards to the unborn child. Good statement. Next. So, these are the concluding statements, and I want you to start looking on the right-hand side. We're going to start on the left. But look at the statement on the right. It has a little bit of a humorous twist, but it is very important to remember that that's apropos show me, okay? Do not do any harm. That's advice to me or any healthcare provider. Respect patient autonomy. We touched on that. And I think sometimes healthcare providers will be authoritative, all right, but do not respect your autonomy. And I think we need to be transparent. And that's an advice from me as a healthcare provider or any of my colleagues. The practice of medicine should be evidence-based, but not solely reliant on the highest tiers of what we call evidence-based medicine, because sometimes they're non-existent. We as healthcare providers constantly need to keep up with the literature, okay? And that's something that you as patients need to make sure your physician does, okay? If they're out of touch because they're busy doing other things in life, which is justifiable, but not for your care, then you need to be, because patients nowadays have access to the same information we do. And it's not very easy to hide the fact that we are not up to date on topics. Okay, so now here's the one on the right. In Chicago, I mean, maybe in many other cities, the speed limit in the highways is 55 miles an hour. So if you drive 55 miles an hour, you'll get run over. Nobody drives 55 miles an hour on the Chicago highways. Same with the practice of medicine. A study has shown that only 15% of healthcare providers actually practice evidence-based medicine. Does that mean that I recommend that it's a jungle out there and we should all make some wild decision? No. But that means that we strive to practice medicine perfectly, but most of us realize we cannot drive 55 miles an hour and arrive to work at the appropriate time. And if anybody wants a little biblical reference, the pericope adulterae, and I'm sorry I'm being, that's my Latin, is the part of, the New Testament, John 8, verse 7, that says, he or she who have not sinned, let them cast the first stone. So what I'm trying to say is most of us physicians and healthcare providers do stray. I guess I shouldn't call it sin, but we're not perfect. And most of us provide healthcare so that because we really care about our patients, sometimes with little merit, but as long as it doesn't do any harm, I think it's worth considering. Next slide. So a few advice to you, patients or relative of patients, consult with your healthcare provider, but make sure he and she are current on the latest. I know I'm repeating myself, but that's important. Read the current data yourself, but obviously you need to use reliable sources. You cannot go on TikTok or Instagram and get your information from there. I'm sorry. Then verify that data that you read about with your provider. I love when my patients come back to me and said, hey, I heard that ambulating right after embryo transfer is better than sticking around even for 10 minutes in terms of pregnancy rates. And I like that because then I can answer that. Ask questions, guys. We're here to answer them. And beware of the social media. Use it carefully. Talk to peers. And of course, a lot of time people say, hey, my friend used this. My friend used that. How about growth hormone? How about ERA? How about Viagra to improve the lining? And I would say, first of all, remember everybody's journey is different, but also remember that you are empowered to be assertive and say, can we please use this or that if it doesn't do any harm? My philosophy is yes, we can, as long as you're well informed. Next slide.
Thank you very much, Dr. Rashid. We covered a lot of interesting topics, and I already see there's multiple questions in the chat box, and I'm ready to start with the Q&A session. Please keep jotting all your questions, and Dr. Rashid, for the next half an hour, will be answering all of them live. So we'll start with the first question. I use Omentrop this IVF cycle, but I wasn't successful. Only 1 egg out of 4 was fertilized. Was it even worth doing it? And I'm 44 years old.
Well, remember that you're desperate and you'll do anything to improve your chance, including growth hormones. So if you look at the scientific evidence, especially the most recent one, there is no merit to using human growth hormone to get more eggs or to mature eggs or get better embryo quality. I still offer it to patients who insist, but I will say it adds to the cost and it adds to your hopes. And they may crash down along with your pocketbook when you use human growth hormone. I try to discourage people from using it, but there's no harm.
Thank you very much. Our next question, can you please touch base a little bit more on embryo glue?
Embryo glue is simply hyaluronic acid, which is a sticky solution that supposedly promotes the embryo staying in one place rather than migrating. And as you saw, the only green light in my, in my whole palette there was embryo glue. So yeah, you should ask your physician or the lab to see if they have it and ask for it. For now, embryo glue, as I was telling several hundred people that were listening to me when I presented it, we had a rapid fire debate a month ago at the Midwest Reproductive Seminar International, and we talked about the fact that most of those add-ons, whether it's lab-related or clinical, are not helpful, except for a few. So you only see a green light. And how do you navigate in a town where the only lights you see are red or yellow? It's hard. But we can do it when we consider yellows and say, well, maybe it's green. So that's the answer.
Okay, thank you very much. So your recommendation would be ask your clinic about embryo glue and get
If
some.
your clinic has it, please ask for it.
Wonderful, thank you. Our next question is, would you recommend Levinox and metformin, even if have tested to show normal A1C and no obvious blood clotting tissues?
Okay, so let's start in metformin. Unless you have PCOS, there's no merit in metformin even if you have tons of eggs, and there's no merit in using metformin. It does not improve anything, especially if your hemoglobin A1C is normal. So I wouldn't use it, and it has side effects. You have to take it every day, nausea and diarrhea. But to improve IVF outcome in non-PCOS patients or non-diabetic patients, there is no merit for that. With regards to Lovenox, and that's an interesting question. If you have antiphospholipid syndrome, if you're habitual, you have your repetitive pregnancy loss, yes. But remember this. Number one, there's no harm in using Lovenox before embryo transfer, but there could be a significant harm if you use it during stimulation. Big no-no, and likewise baby aspirin, because you can bleed from a procedure that's relatively simple, where people usually do not have significant bleeding if your clotting mechanism is compromised. So definitely no Lovenox or baby aspirin when you're stimulating. After that, when you do, many of you will do frozen embryo transfer, Lovenox is okay, except Is there justification for Lovenox if all your blood work for autoimmune studies and thrombophilia is negative? Not really. So Lovenox is not complete anticoagulation. You still have the ability to clot your blood. So God forbid somebody rear ends you, you hit the windshield, you're not likely to get a brain bleed unless you're fully anticoagulated, which is unlikely. But there's also a legal aspect to Lovenox, and that is if I give you Lovenox and something terrible happens to you, an accident where you bleed, I don't have a legal leg to stand on if I could not justify it medically. So baby aspirin Lovenox could be considered before embryo transfer, especially people that have some abnormalities in autoimmune study like IgM anticardiolipin antibody or one in a panel, etc., especially with antiphospholipid antibody syndrome or lupus anticoagulant. Talk to your physician about that.
Excellent. Thank you very much, Dr. Rashef. I'll move quite quickly here with all the questions because we're receiving a lot of questions. So I want to make sure that we answer as many as possible. But our next question is how to choose sperm. Which criteria are most important to filter?
Well, I kind of talked earlier about DNA testing of sperm, and they're not recommended. They're only recommended actually if people with recurrent pregnancy losses. But then again, if your results are not good for your sperm DNA, if you're the male partner, what do we do about that? Do we take antioxidants? Yeah, we try. It may or may not work. And remember that any test is just snapshot in time. So if you are a male partner and you have poor DNA fragmentation, does that mean you're stuck with it? No, it doesn't. But you won't be able to afford doing it every other day to see what the norm is for you. And therefore, antioxidants, including CoQ10, vitamin E, vitamin C, are recommended to maybe rectify that. Now, we look at count motility morphology. Morphology is considered to be probably one of the more important criteria. Morphology is the shape of the sperm. Sadly, even in 2025, we don't have very sophisticated criteria. We cannot test that sperm for DNA. So even the best looking sperm may not have healthy DNA and may not result in a live birth. So we're still kind of a little old fashioned here by actually looking at sperm under the microscope. So you're under the mercy of our technicians. Now, artificial insemination is very promising because if you take the opinion of, let's say, 100 embryologists and you incorporate it into an algorithm and the AI chooses a sperm for you, that's probably more reliable than a tired embryologist that may not necessarily, I mean, that's very subjective. Yeah, we have criteria for normality, but it's still very subjective. So AI actually is very promising in that respect, and AI is very promising in selecting the appropriate embryos, yet it's not yet applicable.
Excellent. Thank you very much. Our next question is, if you can please touch base on Receptiva test and why is no longer recommended, especially if endometriosis is suspected.
Yeah, Receptiva tests basically check for a substance called BCL6. Actually, BCL stands for B-cell lymphoma. But basically, there is a correlation, supposedly, according to some studies, between a positive BCL6 and endometriosis. However, if BCL6 is positive, what do? We have two options. Three, we can ignore it. Why did we do the test then? We can do a laparoscopy to see if indeed you have endometriosis. And that, as you well know, for those of you that have had it, an outpatient procedure that takes you out of commission for about a week or maybe less, but it's an invasive test requiring general anesthesia, etc. And even then, 50% of the people that have BCL6 will not have endometriosis. Or suppress your ovaries with things like Orlissa or Depolipron for 2 or 3 months to make endometriosis, assume that that's endometriosis. So if you want to get tested for BCL6, remember this. In medicine, if you do a test, you need to act upon the results. As they say back where I came from, if you walk in the desert and you pick up a rock, please be prepared to deal with what's under it. Otherwise, don't pick up the rock. So if you have BCL6, what do? I think it's worth a conversation with your physician, whether they give you suppression by GnRH antagonists or GnRH agonists for 2 or 3 months to kind of get your endometriosis down, or surgery, or simply ignore it. So no easy answer. But if you insist, if patients insist on doing that, when we do a biopsy of the lining for chronic endometritis, not endometriosis, for chronic inflammation, I also add that test. It's the same sample.
Excellent. Our next question is, I've been recommended PGT as a standard instead of doing a fresh transfer to increase chances of success and lower risk or miscarriage. Is that correct?
It is correct for a certain subset of people. That's why the Human Reproduction article talks about it. It's not recommended for routine use. So I personally will not offer PGT unless people insist on it under the age of 35, because the proportion of normal eggs and therefore normal embryos is very high. The proportion at age 36 is about 50-50, and abnormal eggs will not result in live borns. Okay. If you insist, or especially if you want to do gender selection at any age, then we'll do PGT. Yeah, and of course, PGT requires biopsy of the embryo, so it's a freeze-all. So the way we do it is we do the in vitro fertilization, and then day 5, 6, or 7, we look at the embryos that are viable. We'll take a few cells from the embryo, from the part of the embryo that becomes the afterbirth, not the baby, and we freeze all embryos. 3 weeks later, we'll get the results, and then we are obviously can do the frozen embryo transfer maybe a month or 2 or later, or even later if you prefer.
And staying on this subject, Dr. Reshev, there is a question about this. Is there any risk of damaging the embryo when performing assisted hatching? Is there been a concern for some with a low egg count?
Not really damage when it's done in places that are experienced in doing that. There is some contention that if you do assisted hatching, you will increase slightly the risk of embryo splitting, and you'll get monozygotic twinning. But for the most part, I mean, it's not recommended routinely. But if your program does that routinely, there's no concern about the health of the embryos if we do assisted hatching in a program that does well.
Excellent, thank you. Our next question is, do you have any add-on advice for patients who are in high weight class?
No. The only add-ons that I can recommend, and you're talking about people with weight issues.
That's correct. Maybe
So obesity is associated with reduction in success rate, more complications during retrieval, more miscarriages. And overall, once you're pregnant, you have more complications in pregnancy. And I don't mean to go into a litany of what can happen if you're overweight or obese and trying to get pregnant or successful in getting pregnant. But weight loss, and I know it sounds all kind of old. It's not easy to lose weight. However, the GLP-1 receptor agonist and their cousins, the semaglutide or tirzepatide, have been shown to be extremely helpful in weight loss, and that's primarily tirzepatide, the Mounjaros of the world, or and as opposed to Ozempic. I mean, people on the average may lose over a year's time more than 20% of their body weight. And that may result in improvement in your chances of pregnancy. So add-ons, unless you include diet and injectables as add-ons, it's not considered to be. I think they're the ones most helpful in optimizing your chance of pregnancy and live birth.
Excellent, thank you. Dr. Reshev, you touched base on ICSI procedure in your presentation, but would you mind please explain to our patients on the call today what procedure entailed and why it's being recommended in the first place?
So the Belgians in 1992 found that if you inject individual sperm with a little tiny needle into the egg, you may improve the chance of fertilization, especially in people with severe male factor. So initially it was people that had no hope and had to resort to donor sperm or adoption. And then we expanded the use of ICSI, intracytoplasmic sperm injection, which once again is the injection of individual sperm as selected by the embryologist directly into the egg. Many people that do PGT now automatically, the labs recommend to do ICSI. Any hint of male factor, especially if the male factor is severe, ICSI. So we use it. But there is, if you look at studies in people, normal male, no male factor, normal sperm and all that, there is no major advantage to ICSI. Okay, it's not going to do you any harm. And clearly, under certain circumstances, it will help you, especially with severe male factor. It's a miracle for people who otherwise would have been considered sterile before 1992. But it's not something that should be used universally.
Thank you. The next question is not necessarily on add-ons, but I think it's very important to address that. Our patient is 33 years old and she had miscarriage on September 24th, and I was advised to wait for my next period as I have PCOS. Should I wait or should I reach out to my doctor?
Well, people with PCOS may not have periods, so that period may never arrive. They can easily induce a period by giving you progestins, whether it's Provera or Prometrium, etc. I normally recommend it, depending if it's just a biochemical pregnancy, there's no problem in getting pregnant with trying to get pregnant with the next period. If it's more of a advanced pregnancy, especially beyond 8 weeks, you might need to wait a couple of months in order for the uterus to clear all the excessive tissue, whether it's parts of the pregnancy, even if you had a clinical miscarriage or they even did a D&C, sometimes there are certain parts that may remain and may interfere with your chances. So a couple of months for more advanced pregnancy beyond 8 weeks, between 4 weeks and 8 weeks, obviously that's controversial if you need to wait. Biochemical pregnancy, which means positive HCG pregnancy test, but no gestational sac by ultrasound, there is no reason to wait until after your HCG goes down to negative.
Thank you. Our next question, and I apologize for reading them, straight one after another, but we're just receiving a lot of questions today. Patients is asking if they have a fibroid, can they get pregnant with the help of IVF?
Yes, but remember there's different types of fibroids. Fibroids by themselves do not cause infertility. Fibroids, if they're in the cavity of the uterus or creating a dent in the cavity, may cause miscarriages or lack of implantation. So those types of fibroids need to be removed because once again, it may cause lack of implantation, especially in an expensive and extensive process as in vitro fertilization. Fibroids that are in the muscle of the uterus or outside probably do not have any bearing on your chances of getting pregnant, but the large ones, of course, will cause symptoms that are very bothersome: pain, pelvic pain, pressure on the bladder, pressure on the rectum, heavy bleeding, significant menstrual discomfort, and all that. So you don't look at fibroid and categorize them as one. Those that are inside the cavity need to be removed. Those that are putting a dent or impinging on the cavity need to probably be addressed, either shaved or removed. And those that are in the muscle or just outside sitting on top of the uterus may not necessarily have to be removed.
Thank you. The next question is, will doing both PGT-M and PGT-A increase the risk of embryo damage or reduce implantation?
So what you're asking, whether we're doing both PGT-M and PGT-A will increase the likelihood of embryo damage? Normally not. Normally not. And once again, if people you're in a program where people do it and they're good at what they're doing, the answer is no. All you need is a few cells from the part, as I said, that it's not the baby. It's called the trophectoderm, that the part will become the placenta, which apparently has the same genetics as the baby itself, but that should not cause any more harm.
Thank you. Dr. Reshef, you mentioned that you often recommend treatment modalities that may not always be completely evidence-based, as there's no enough data right now. What modalities do you personally recommend to your own patients that may not have the green light on that study you mentioned?
Well, you saw my presentation. There were hardly any green lights, but some of the yellow lights, especially those that can be considered CBC, we discuss it. So, and to be honest, I use growth hormone if patients request it, but I discourage them. But if they say, well, I want to give it a try, my friend used it. I said, here it goes. It's not going to cause any side effects. It may not have any merit, may be very expensive if you have to pay for it from your own pocket. But I'll do it. Baby aspirin, I don't have any objection to using it before embryo transfer and until we have a positive pregnancy test. But stop afterwards, okay? When you have a positive pregnancy test, stop baby aspirin because many of us know what subchorionic hemorrhage is, and that's bleeding underneath the placenta, which is very common after embryo transfer, whether it's fresh or frozen. And if you don't have the mechanism to clot, and remember, if you take baby aspirin, your platelets are compromised, and therefore your clotting mechanism are compromised for a whole week after you took the last baby aspirin. And so that may contribute, and likewise heparin, to subchorionic hemorrhage and even potentially miscarriages. So as soon as we have a positive pregnancy test, stop them unless you have evidence like antiphospholipid syndrome with positive lupus anticoagulant, or you have some of the other panel products that are positive, like anticardiolipin antibody, anti-beta glycoprotein antibodies. Some of those in a normal panel that are positive, then I recommend to continue using it, and then it's for your OB to determine when to stop it.
Okay, thank you. Our next question is, in my case, there was 10 eggs, just one made it to embryo and none reached the blastocyst stage. What can I do to improve my chances and have more fertilized eggs?
It's a question we hear every day, and it's a painful question because the answer is very uncertain. Remember, if you have diminished ovarian reserve, and 10 eggs is kind of on the cusp, it's not diminished ovarian reserve, but every part of IVF, there is a decline or decrease in the yield. We don't always get all the eggs that are promised by the ultrasound. We don't always get all of them to be mature. We don't always get those mature to fertilize. We don't always get those that fertilize to become embryos, and those that become embryos some of them will not become blastocysts. So one embryo out of 10 is a low number. The question is it the stimulation protocol? Is that your problem and you cannot cure it? Clearly, if you're a smoker or heavy drinker, and there aren't a lot of lifestyle issues that can harm eggs. Smoking actually is, but that's really the only one. Not even drinking, believe it or not, will harm egg quality. So what you're left with is usually no answer, but remember that if you try again, and I know it's easier said than done, you may get different results unless you've been experiencing it over and over, that out of X amount of eggs, you have no embryos surviving. There's lab factors, there's egg factors. It's daunting both for you as a patient and for me as a physician.
Dr. Reshef, what are your thoughts on intralipids?
The answer is no, but here goes. I don't give it. It doesn't have any merit in our literature, the reproductive literature. However, if patients ask to be also co-treated by reproductive immunologists and the reproductive immunologist gives them intralipids, I absolutely would collaborate with that particular person as long as she's advised by me that according to my literature and larger studies, it doesn't have any merit, but it doesn't do any harm.
Okay, wonderful, thank you. How do I know if fresh or frozen egg transfer is better, one or another?
Okay, fresh or frozen transfer. Good question, because in every program, they have their own statistics. They can tell you if the results from fresh or frozen are similar or one has advantage over the other. The majority of our transfers are going to be frozen because many have PGT, and especially when it comes to people who stimulate well and are at risk for ovarian hyperstimulation syndrome, in which case we reduce the chance of ovarian hyperstimulation syndrome by freezing all that the ovaries come down and then do the frozen transfer, especially since, at least in our program, we have at least as good results or better with frozen. However, every program should have its own statistics, and you need to ask your caretaker how it works in their program. For example, more and more programs will go to frozen only. Fresh sometimes is offered to people with diminished ovarian reserve. And the rationale is put the embryos in while fresh on day 3, maybe day 5, you tuck them in there so they don't deteriorate in the culture. Not unreasonable. And remember, in the old days, we used to do mostly fresh transfers on day 3. The better results are with blastocysts, and the better results in most cases are day 5, fresh transfer or frozen transfer. Day 3s oftentimes are left for people who have questionable quality embryos. And therefore, their success rate is compromised anyway. So you cannot compare people with diminished ovarian reserve that have fresh embryo transfer on day 3 to the rest of the population with better prognosis.
Thank you. Can you please touch base on effect of alcohol on the pregnancy and success rates, and does this impact the results? How about exercise, and if there's any dietary restrictions that you would recommend to follow?
Let's start with the male. Alcohol and excessive use may compromise sperm, and that's more than one drink a day, especially when people that binge over the weekend. So we discourage them from drinking more than one alcoholic drink a day on the average, and preferably less. In women, alcohol has not been shown to affect egg quality unless people are obviously in the category of alcoholic. But clearly, there's less of an effect on egg quality and embryo quality if you drink. And clearly, drinking socially will not impact anything in your stimulation cycle. However, after your embryo transfer, no alcohol, guys. Now, fetal alcohol syndrome is usually more typical to people who drink quite a bit, but it's a devastating negative medical condition in the baby, and you don't want to go there. People ask about caffeine, and caffeine is not deteriorating and doesn't cause any problems with the male sperm. In women, I usually say once pregnant, go down to maybe one equivalent a day if you cannot quit altogether. So limit your visit to Starbucks after you have a positive pregnancy test, but otherwise during stimulation or preparation, you can drink as much as you wish.
Thank you, Dr. Resha. Next question is the hysteroscopy recommended for chronic endometritis?
Yes. And really, I mean, you don't have to have hysteroscopy for chronic endometritis. You can do a biopsy. They're typical when we look directly into the lining of the uterus. You can sometimes look at the vascular pattern, the blood vessel pattern. You can say that could be chronic endometritis, but the ultimate is what goes on in the lab. So for chronic endometritis by itself, I do a biopsy because the pathologist will look at the biopsy under the microscope using a special stain called CD138, and they will look for plasma cells, which are part of the blood cells that involve with chronic, not acute, chronic inflammation. And the presence of plasma cells indicate chronic endometritis, and in most cases, it's fairly easy to treat with a couple of weeks of antibiotics.
Thank you. The next question is, I'm currently in the process of frozen embryo transfer. I was prescribed the regular injections and medication, but I was given the option of progesterone in oil injections. It was recommended by my physician, but they told me it is optional and it's up to me to choose it or not. What are your thoughts on that?
Well, progesterone in oil is painful. It's intramuscular. It causes pain, lumpiness, sometimes local and general allergic reaction. So literally pain in the whatever. But if you look at studies looking at success rate from embryo transfer, they have the better results. So you have to negotiate with patients. If patient cannot stand it, you can change the oil. ethyl oleate to olive oil. Some people cannot tolerate this, and you switch it to that. And people that cannot tolerate it, we either go to an alternate day progesterone injections with vaginal in between or completely vaginal. So, yeah, if you look at the literature, progesterone in oil is still the most effective way to provide support for the lining and get better implantation and pregnancy rates. However, it's very unpleasant to take progesterone in oil, and you have to take it deep in the muscle, and oftentimes patients cannot inject themselves, so their friends, spouses, partners should do it. It's painful, but apparently people oftentimes are willing to compromise on that discomfort for the sake of getting pregnant.
Thank you very much, Dr. Asher. Can you please as well touch base on how often and what the interval the patient should wait between the IVF cycles?
Well, the old-fashioned way is to rest a cycle in between. You don't have to. Okay. Obviously, there's not only the physical issues. The physical issues, will your ovary stimulate again? And DuoStim can be used back to back to get more eggs overall. DuoStim actually has not been shown to produce better pregnancy rates, interestingly, as disappointing as it is. But I tell my patients, it's your choice. And sometimes as a matter of insurance, will they pre-authorize a back-to-back cycles? Will your clinic schedule will allow it? But I don't have any problems with back-to-back or waiting. Sometimes also there's the emotional factor. I mean, you've gone through the roller coaster. And everybody that has gone through IVF is familiar with that roller coaster. It's daunting. And then, are you ready for another round? But there's no contraindication to starting right away.
Thank you very much, Dr. Asher. Do you mind extending the session for 5 more minutes since we started a little bit later? I want to be able to
for as long as you wish.
To answer a couple of more questions here, but is there any specific add-ons that you would genuinely recommend for female 40 plus?
Well, the usual ones that we recommend is CoQ10 and prenatal vitamins and some antioxidants. But if you look for the evidence, you won't find it. It's not going to do any harm. If there are any lifestyle issues, and for the majority of people that we see at least, there are no major lifestyle issues like heavy smoking, heavy drinking, or daily doses of marijuana. Even that has not been proven to affect egg quality. But and dietary changes and weight loss, those are recommended regardless of what age you are. But remember that all of those recommendations do not have a strong scientific base. Nevertheless, they do no harm, so I do recommend them. It's empowering for people to use add-ons, because otherwise you just sit there and say, well, the definition of stupidity is doing the same thing over and expecting different results. Well, newsflash, in reproduction, it's not stupid, because every cycle, especially in people who are older, has different group of eggs and different outcome. So you can do the same thing over, same protocol and all that, and get different results.
Thank you. Is there any particular supplements that have evidence around the effectiveness in improving IVF outcomes
No.
at the moment?
This is a short answer and a disappointing one to most of you. But remember this, there's no objection here to traditional Chinese medicine or Ayurvedic medicine or any alternative medicine and any vitamin or supplement therapy that's not injurious. But beware, because if you, let's say, indiscriminately use, let's say, Ayurvedic medicine has been practiced in India for thousands of years, beware that some of the substances, whether it's ashwagandha or ginkgo biloba or ginseng and all that, have anticoagulant activities. If you're already using heparin or Lovenox and baby aspirin, you'll get in trouble. A patient of mine years ago got in trouble with the heaviest of bleeding and a significant loss of blood, not from IVF, showing up in the emergency room in southern Texas with hemoglobin critical. And a smart resident asked questions, and turns out she was using a lot of those Ayurvedic medicine and baby aspirin that I just mentioned, and that was a cause of herb, heavy bleeding, and significant anemia. So beware.
Thank you, Dr. Reshef. The next question is, please throw some light on embryo scratching. Can one do both embryo scratching, sketching, and embryo glue during the frozen transfer of embryo?
Are you talking about assisted hatching and embryo glue?
Yes, that is correct. I believe that is the
Yeah,
question.
they can be practiced, and you can discuss it with your physician or your embryologist, because every lab has its own preferences. Okay. And so that's why it has to be individualized. As I said in the beginning, I represent myself. I'm at Advanced Fertility Center of Chicago, and my opinion may not necessarily hold, or not all the add-ons that I use or my lab uses are available in every lab. So subject for discussion and debate.
Thank you very much. We will touch base on one last question for tonight, and we will try to export all the remaining questions from today. We still have 76 more questions to go,
Wow.
but we will try to get a social post and get back to you with all these questions. But the last question for today. After this first IVF cycle, my TSH went from 2.3 to 3.45, and now I'm going to start a small dose of Synthroid 25 msg. Can the body get used to receiving this hormone that when I'm done with my goals, my thyroid will not readjust on its own and be a possibility dependent on Synthroid for the rest of the life?
So remember this, and that's why it's important to read the new literature. The American Society of Reproductive Medicine issued new guidelines of thyroid supplementation for people that are considered to be subclinical hypothyroidism, meaning they don't have symptoms of low thyroid, but they have elevated TSH. So as of 2 years ago, it was TSH of 2.5 and under. Now it's 4 and under. That's considered normal. So we eased off on putting people with supplementation with levothyroxine, or Synthroid is the name of some of the preparations. We now use less of that because there's no evidence of subclinical hypothyroidism. Even those that have over 4 may increase miscarriages or worsen the outcome of IVF. But if the level of TSH is over 4.0, I will give low dose of levothyroxine. Remember, it takes a month and a half to 2 months at least for the thyroid to finally find its new mojo. So theoretically, if you check people, if you add a dose or change a dose, you cannot do it next week. The no TSH, you need to wait at least 4 to 6 weeks.
Thank you, Dr. Asher. I know there's so many unanswered questions today, but if you would like to get in touch with Dr. Reshef and ask all the questions during a consultation, I believe you do telemedicine consultations as well, Dr. Reshef. Please correct me if I'm wrong.
Most of mine are.
Right. So please book your appointment. Most of the consultation usually covered by insurance, and have the opportunity to ask all your questions directly from Dr. Reshef. He's an excellent physician. Again, Advanced Fertility Center of Chicago. Thank you very much for joining today's webinar. We host this webinar on a monthly basis, so please join us and have opportunity to speak with a physician.
Irina, if I may, final statement. I know that this particular webinar has disappointed many of you because you are so hopeful, especially you're going through the fertility journey, and all of a sudden I rain on your parade here. But again, the idea here is not only to give the medical evidence, but also to give some leeway and respect your autonomy. On the other hand, my patients do not get false medical information from me because I constantly read and get updated, including that very substantial study that I just quoted. And it changes all the time. So if there is an add-on that we find in the literature that's promising, we offer it if it's not dangerous, oftentimes with the caveat, hey, not yet evidence, but no harm done. So use your assertiveness and autonomy and discuss it with your physician.
Thank you once again, Dr. Reshef. Really
Thank you,
appreciate your
everybody.
time. Thank you. Have a good day.
You too.